issues can be addressed. I think that really summarizes the complete presentations. I think thank you so much. I'm sure there will be many questions. We will, before going for that part, we will go to the next presentation. I think let me now invite Professor Usha to introduce the next speaker.
And thank you, Shri, for wonderful presentation. So our next speaker is Dr. Sayantan Banerjee. Dr. Sayantan Banerjee is an infectious disease physician with an undergraduate training from Medical College, Kolkata, postgraduate training and residency from Maulana Azad Medical College, New Delhi, Delhi University, postdoctoral training and residency from AIIMS. He also has a postdoctoral diploma of clinical microbiology from the National Board Examination India and a postgraduate diploma on combined clinical microbiology and infectious disease from the Royal College of Pathology, UK. Sayan also has a fellowship from the Royal Society of Public Health, the UK, to his credit. Since September 2019, he is working in WHO Southeast Asia region in the field of antibiotic resistance and COVID-19. Today, Dr. Sayan shall speak on his personal behalf and not represent WHO officially. He has previously worked as consultant AMR, WHO CRO, consultant infectious disease ICMR, senior resident and postdoctoral fellow infectious diseases at AIIMS. He also worked as an associate professor, clinical microbiology, and as a senior resident, clinical microbiology. Sayan has interest in the areas of infectious disease, outbreak management, and health system development to deal with any dangerous pathogen outbreak response, biosecurity, antibiotic resistance, and national medical disaster management, setting up of outbreak management laboratories, popularization of science in vernacular languages at high school and at the community level. He is also interested in state-of-the-art and attractive methods for medical education, particularly for the last mile students in small towns. So with that, I thank you for accepting our invitation and request you to go ahead with your presentation. Thank you. Avinash, you have to unmute. Yeah.
Thank you, Professor Usha, for your kind words. And I'll tell you that I'm really honored to present to this august audience of the faculty members, students, and other audiences of this International Institute of Population Sciences on this special day of World Population Day. In the beginning, I would just like to thank my previous speaker for being so exhaustive and giving so detailed insights of her experience on public health and health policies. I would say that rather I'm very new in public health, and I have specifically chosen your platform to deliver my expectations towards the public health specialists, my expectations towards the demographic scientists, the population scientists, from the perspective of a clinician. And I'll be very frank that I have mostly hospital-based experience throughout my career, and I have been doing public health with my current organization, WHO, for only last 6-7 months. So now, if I can share my content. Yeah. So basically, what I intend to tell you today is what the country or what the world now needs from the population scientists to contribute beyond the usual contribution that we have been seeing from what we call the COVID warriors, health warriors, of the frontline workers, the clinicians and the nursing staff who are there working on COVID-19. Okay, so just for beginning, I would say that enough has been discussed on the virus and the disease. Now we all know that COVID-19 is a coronavirus, which is, we have about 7 or 8 coronaviruses which can affect human society, which can affect human beings. And out of this 7-8 coronaviruses, only 3 coronaviruses have been found to be dangerous. Initially, we had the outbreak of SARS coronavirus, which started from China in 2002. And then we had the outbreak of MERS coronavirus, which was the Middle East respiratory syndrome coronavirus in 2012, which started among the Hajj pilgrims in the Middle East, Asia. And now we have this new SARS-CoV-2, severe acute respiratory syndrome coronavirus 2, which is causing this current COVID-19 pandemic. And if you've seen these 3 coronaviruses, other than these 3 coronaviruses, there are 4 routine coronaviruses, which will cause normal, what we call upper respiratory tract infection, a little bit of running nose, a little bit of cough, sneeze, and maybe a little bit of low-grade fever. And we all, how many participants are here listening to my presentation? We all have probably suffered from one or the other coronaviruses in our life. I'm not talking about SARS, MERS, or SARS-CoV-2. I'm talking about the routine coronaviruses, which causes simple respiratory tract infections. Now, we have to understand that how this COVID-19 is different from those. If you see the mortality rates of SARS-CoV-2, it was SARS-CoV, the initial SARS, it was close to 10%. If you see the mortality rate of the Middle East respiratory syndrome coronavirus, it was close to 30 to 36%. And if you see the recent mortality of SARS-CoV-2, the mortality rate is varying every day depending upon the denominator that is changing. Initially, we had a mortality rate of 6%, depending upon the denominator, the number of cases that we have diagnosed being smaller. Now, as the number of cases being diagnosed more and more, we are having a reduced mortality. It was close to 3% almost 2 months back. Now it is varying between 1% to 4% among different evidences that are coming up. I will also discuss about the fallacy of the denominators that we have. The fallacy of the RT-PCR positive cases, if they are taken as the total number of cases. They are only the tip of the iceberg. I'll come to that. Now, despite of being a lower mortality disease than SARS-CoV and MERS-CoV-2, COVID-19 has paralyzed the entire world for the last 3 months plus. We have lockdown going on in India since 24th March. And today we have more than 3 months of lockdown already done. We have thousands or I'll say millions of people losing their livelihood, losing their jobs, severe stress, mental health issues, suicides happening, people migrating in miserable conditions from one state to another on foot, on road. So this huge amount of disruption that SARS-CoV-2 has done is absolutely unique if you compare to the mortality rate of SARS, initial SARS of 10% and MERS-CoV of 36%. We have a much lesser mortality disease. If you see the R0 of this SARS-CoV-2, you'll see an R0 of measles is close to 10 to 15, chickenpox, smallpox, everywhere the R0 is much more than 10. Here we have an R0 arguably between 2 to 3, maybe mostly 2.5, 2.7. In certain settings, R0 is high. I will discuss about R0. Still, this disease with a mortality rate of 1%, where you had, in Ebola, you had a mortality rate of 40% and on R0 close to 20. But still, this disease has overwhelmed the entire health systems and everything that we see around us. We are discussing about everything, about the health systems, about the chronic disease that are managed, about the vaccination, about the maternity care, about the livelihood. So what's unique in this disease? The uniqueness in this disease, what I presume, are basically two. One is, if you have a kind of disease where the transmissibility is very high, but you have very florid symptoms, you have jaundice and hemorrhages in your mucous membranes, eyes and skin, and it can be recognized very early, like Ebola. The transmissibility can be avoided just by panic and people, people actually avoiding to get in close touch with the patients. If you have something like the smallpox, where you have, vesicles all over the body, people, despite of more mortality, despite of more transmissibility, are not, people tend to avoid close contacts. But in SARS-CoV-2, unlike SARS-CoV and MERS-CoV, in SARS-CoV and MERS-CoV, you had a more number of symptomatic patients, a more severe pneumonia, and less number of transmission from pre-symptomatic, asymptomatic, or less symptomatic patients. Whereas here, you have a virus which gets transmitted very quickly, even in pre-symptomatic and asymptomatic conditions, or in mildly symptomatic conditions, when another person does not refuse to come in close contact with actually an infected person. So this is the reason for which it has overwhelmed the system mostly. Okay, now, if you see the numbers, we are every day we are having more and more and more numbers than the day we have reported earlier. Today, we have in India, we have more than 8 lakh cases. And Bengaluru has reported almost 6 times increase in numbers in a few weeks. And in Delhi, the numbers are getting overwhelmed, in Mumbai, in Calcutta, everywhere. So how do we plan to reduce and mitigate this load? Now, being a clinician, I was in charge of looking into the rapid research and innovation models that would help to mitigate the COVID-19 crisis. Initially, like everybody, we were looking after more and more medicines, and we are looking after better ways to ventilate people, increasing the ICU facilities, as initially people were discussing with industrialists to produce more and more ventilators in India, import ventilators from USA, etc. Later on, almost 3 months back from now, I realized an important fact. I would pause my screen sharing, and I will come back to my So what I realized is, if you see the mortality data of ARDS, these are few names with which people have become very familiar right now. ALI, acute lung injury, ARDS is acute respiratory distress syndrome, ILI is influenza-like illness, and SARI is a severe acute respiratory infection. These are a few terms with which you have become familiar. Otherwise, I will also explain what is this. So what happens in COVID-19 is, when the virus goes in, it usually gets in through aerosols transmitted by the sneezing and coughing of infected patients, or when the virus is settled on an inanimate object, you touch it, and then from your skin, it gets introduced through your mucous membranes in your lips or conjunctiva, or if you eat something from the hands, it gets through your mucous membrane. So initially, the virus goes to your pharynx, the oropharynx and nasopharynx. And for most of the cases, the virus mostly stays there, creates a little bit of upper respiratory tract infection, sore throat, cough, a little bit of dribbling from nose, and a little bit of fever as an inflammatory response, and it goes away. And in some cases, it goes lower down to your respiratory tract, to the lungs, where it starts killing the respiratory epithelium, the alveolar cells, where it goes into the respiratory epithelium, it starts multiplying, it bursts out, it comes out, and it kills the respiratory cells. And your own immune system feels that there is a threat. It comes out and it fights against the virus. An inflammatory reaction occurs. And with this inflammatory reaction, what happens is the respiratory membrane, where the gas exchange takes place between your inspired air and the blood, the oxygen comes in, then the carbon dioxide goes out. This respiratory membrane gets damaged, it becomes opaque, and the gas exchange gradually fails to occur as it should occur. This is a condition which we call acute lung injury. Okay. And when it progresses further, we call a condition ARDS, acute respiratory distress syndrome, where even if you give more and more oxygen to the patient, the oxygen in the blood level fails to increase as it should have been increased. This is called a mismatch of PF ratio, which is the proportion of the inhaled air oxygen, and the proportion of the blood oxygen varies. Okay. Now, what happens if you see the treatment modality in this kind of ARDS patients? When a patient progresses to ARDS, what we need to do is the patient needs to take more and more breath. And with the more and more breath, the patient gets exhausted. And when the patient gets exhausted, energy depletes, then the power to take more and more breath, more and more oxygen is very limited. So we need to give oxygen from outside, and we need to, for reducing the load of breathing, we need to provide something called the mechanical ventilation, which actually pumps in the oxygen and the air to your lungs. This is what we manage ARDS by mechanical ventilation. ARDS can occur due to various reasons. It can occur due to toxic gas inhalation. It can occur due to n number of infective pathogens having severe pneumonia, viral pathogens, bacterial pathogens. Okay, it can happen due to many causes, chemicals ingested or sprayed somehow. If you inhale aerosols of chemicals, it can happen due to many reasons. Now, if you see the mortality rate of mechanically ventilated patients due to ARDS, irrespective of COVID-19, between 2015 to 2019 in India, from the best available hospitals like AIIMS Delhi, PGI Chandigarh, SGPGI Lucknow, KEM Mumbai, and CMC Vellore, you would be surprised to see that in India we have almost 50% mortality rate for mechanically ventilated patients who suffer from ARDS. If the mortality rate is 50%, and if you compare that mortality rate with the mortality rate of mechanically ventilated patients in COVID-19, you would see that the mortality rate do not vary much if ARDS happens. So what I realized 3 months back is if ARDS happens in COVID-19, the mortality rate wouldn't vary from a non-COVID-19 related ARDS or a COVID-19 related ARDS much. So you can't actually reduce the mortality, mitigate the mortality by only ramping up your ICU and ventilator facilities. What we need to do is we have to prevent entry of COVID-19 positive cases into ARDS. We have to prevent the progression of COVID-19 into severity. And we have to prepare our system for halting or delaying this progression, as well as we have to build up our ICU and ventilator system. But even though we build up our ICU and ventilator system to a great extent, the mortality rate of ventilated patient is unlikely to come down below 40% or 30% if the patient gets ventilated. Okay. So what is needed to be done? 3 months back, we understood. I was working with Professor Usharam and some other demographers and population scientists, and we understood that when India declared the lockdown on 24th March, which was very vital, I will tell you why is it vital. What happened is physical distancing was limited only to the middle class and upper middle class urban people who have enough indoor floor space per capita, and to some extent in rural population where I would say a little bit of affluent rural population where the indoor floor space per capita was bigger. When India, now what was the role of lockdown? If we get back to the presentation again. Am I being able to present? Yeah. So if we see that how a disease in epidemic spreads, and what are the factors which denotes the spread of the disease. You know, everybody of us who are population scientists, epidemiologists, and public health specialists have heard by the time the term called R0. The R0 is the basic reproductive number that we have. So this R0 is basically for every disease, for every epidemic, it is calculated after seeing a disease, how it behaves, how it spreads in a particular geographical area, and it's a retrograde calculation. Okay. For COVID-19, we have R0s observed in different clusters of epidemic that has occurred. We had an R0 from Hubei, we had R0 from Iran and Italy, and now we predict the global R0 or area-specific R0s to be something. Okay. Now this R0 means that after a given amount of time, from one case, how many cases gets infected in a susceptible population. For COVID-19, most of our population or all of our population is susceptible because there is no background herd immunity, there is no vaccines available. Okay. This R0 is dependent upon three factors, T, C, and T. What is T? Now T is transmissibility. Okay. Now this transmissibility means if I am infected, I come in close contact with 5 other persons, then what are the factors within these 5 other persons that would prevent transmission from me to them? If we had vaccines, it would have reduced transmissibility. If some of these, 3 out of these 5 patients have already been infected and have a good amount of antibody against COVID-19, they would have prevented transmission. Nowadays, we have strange observations coming up where we can see that immunity, the immunoglobulin levels are not raised for all the patients, and almost 6% of recovered COVID-19 patients have no detectable antibody. That's a separate issue. Other than that, almost 94% of the patients are having some degree of immunity, which will prevent COVID-19 transmission. And there are certain, things coming up. People are telling that if you take vitamin C, vitamin D, zinc supplement, etc., you will have boosted immunity, which I would say have less evidence right now. I don't think, and there are Ayurvedic medicines coming up, which I believe is not yet peer-reviewed and evidence-based. So we don't have much thing in our hand right now to reduce the transmissibility. The next factor that I would come, the last factor is duration of infectiousness. That means for how long am I shedding the virus? If I shed the virus for too long and I am in close contact with you, you have chances of getting infection more. If I shed the virus for a lesser number of time, you have lesser chance of getting the infection. And if we have certain good drugs which would immediately decrease the viral shedding, as it was claimed by hydroxychloroquine or azithromycin initially in the French study conducted by Professor Didier Raoult, that hydroxychloroquine and azithromycin probably reduces the viral shedding, which we found later on is not as much as substantial than it was claimed initially. If we have some such kind of a disease, such kind of a drug, then we can reduce the duration of infectiousness, by which R0 can get reduced. But till we don't have vaccine or enough herd immunity to reduce the transmissibility or a drug to reduce the duration of infectiousness significantly, we could only manage the factor of C, that is the average rate of contact. The factor of C was mitigated or was tried to be mitigated by the governments all across the world by imposing 2 things. One is physical distancing or social distancing through lockdown and encouraging to stay at home. Number 2, by promoting universal use of masks. What does it help? See, if you see this slide, one index case comes in and let us presume an R0 of 2. And let's presume the condition like COVID-19, where from one generation to next generation of infection takes an average of 5 days. So in 1 month, you will have almost 30 by 5, that is 6 generations of infection. And if the R naught is 2, you would be getting 2 to the power 6 number of cases from one case within a month. The total number of cases will be the initial case plus 2 square plus 2 cube plus 2 to the power 4, 2 to the power 5, 2 to the power 6. That is total number of 127 cases if the R naught is 2. In COVID-19, if we consider the R naught to be 2.5, the total number of cases that is expected within a population from one single case is roughly 406. If you do this calculation, it's 1 plus 2.5 plus 2.5 whole square plus 2.5 whole cube, etc., reaching to 406. Okay, this 406 number of cases individually, if they enter into different communities again, can also give rise to another 406 cases individually. If we take of a contained community, it is from one case 406 cases. And if these 406 cases individually migrate, they can also give rise to potential 406 number of cases in 30 days. This is a theoretical model. Now, when I was discussing about C, average rate of contact, if we can reduce the average rate of contact to half, suppose I have stopped going out into meetings and cinema halls and movie and programs and IIPS delivering the lecture through online. I'm actually meeting much less number of people than I used to meet before. If we just apply mask, meet less number of people, stay at home, and through this lockdown, if we reduce the C to half, then the R naught will also proportionately get reduced. Now, what will be the R naught? If we reduce the C to half and the R naught becomes 1.25, the magic is the case number that occurs from one single case within a month will be 1 plus 1.25 plus 1.25 whole square plus 1.25 whole cube, etc. Apparently, the number doesn't seem to be less. But if you do this calculation, you will be surprised to find out that this total value is coming to only 13.8 or 14. That means if we reduce the R naught from 2.5 to 1.25, the potential number of cases that occur from one case will get reduced from 406 to 14. For this, you just need to calculate this. Okay. So this is the basis of promoting mask and promoting lockdown and isolation. But what happened when we promoted lockdown? Okay, the lockdown actually didn't work well for physical distancing in the urban slums and the resettlement colonies and the densely populated lower income group residential clusters in the urban societies. Okay, what happened is with the lockdown, actually, there was physical nearing instead of physical distancing within this slums and densely populated areas. So instead of actually the R naught diminishing, in certain areas the R naught actually increased. You know, there are case studies where we have seen that, you know, 6 migrant workers from Bihar or Uttar Pradesh who are taxi drivers were living in one small 8x8 room in Dharavi slum. They had hired 3 taxis with them, and 3 of the drivers would go for a morning shift with the taxis out. They would come back in the evening, and 3 of their other friends would go for a night shift normally. And normally in that 8x8 room, 3 of the 6 drivers would sleep. Okay. What happened in lockdown, with the lockdown and closing of the Uber, Ola, and all these cab taxi services, the 3 taxis got halted, and the 6 drivers got locked inside the slum 8x8 room. Initially, if you see, ma'am before me was speaking about the migrant workers. If you see the cases of migrant workers, when the lockdown was implemented on 24th of March, initially for only 3 weeks, you have seen that a lot of migrant workers started walking from Delhi, Mumbai to their native places in Chhattisgarh, Madhya Pradesh, Rajasthan, Bihar, UP, or West Bengal. Immediately after the lockdown was started, These were the migrant workers who were the marginalized of the marginalized migrant workers who were working as, mostly as construction laborers in the urban construction setups, who did not come in close contact with the initial imported cases. The initial imported cases that has flown in from China, Thailand, Iran, Italy, Middle East or Europe. These initial imported cases were not in close contact with the first wave of migrants. So the first wave of migrants didn't test positive at all. Later on, when the cases of cases started increasing and the lockdown was more and more and more increased, then a little bit of well-to-do migrant workers who were taxi drivers, who were, workers, housekeeping workers of hotels and airports, housekeeping workers of the aircrafts, commercial sex workers, and other service providers who have come closer contact with the initial imported cases, they also started migrating. These people, for the last 1.5 months, were actually almost the amplifier host of the disease in the urban slums and the densely populated lower income group residential clusters. That's why in the second phase of migration, we had a lot of boom of cases from Jharkhand, Chhattisgarh, and West Bengal and Bihar, which was not seen in the initial case. Okay. So now we are about to close down the lockdown. We are going through the processes of opening up of the lockdown. So if the opening up of lockdown occurs in current situation of 8,20,000 cases right now, what will happen? My first question to you is, do you believe the numbers, this 8.2 lakh number of cases? Do you believe that this is the number? I will give you a few examples. There is a seroprevalence study from Spain, which showed that approximately 5% of the population of Spain is infected in May. There is a seroprevalence study from Geneva Canton, which has shown that for every RT-PCR cases that are diagnosed, there are about 11.6 or 12 transmitted cases in the community which are undiagnosed by PCR. If you see the recent seroprevalence study published, I would not say recent, in April from Santa Clara County, you would see that the seroprevalence was 2.8%. And if you see the number of cases diagnosed by PCR is to the actual burden, it is more than 1:55. If you see the seroprevalence study of Delhi right now, seroprevalence is 15%. The total number of cases reported is close to 90,000, as opposed to 15% of almost 2 crores, that is 30 lakh of total burden of disease. So we have more than 1:30 number of community cases than that is actually reported in RT-PCR. And if you see the ICMR's data of Kolkata's seroprevalence, Kolkata had been reported to have a seroprevalence of 14% in May, when the actual number of reported cases in Calcutta was close to 3,000. And if you see Calcutta's population of 50 lakhs, only the Calcutta district, and the the larger Calcutta suburban area of 1.5 crores, if you compute the seroprevalence, it is coming that almost for every RT-PCR positive cases, you have 300 number of undiagnosed cases in the society. So what I'm trying to tell is, probably we have a huge number of undiagnosed cases in the community than the number of cases that we are seeing. So in this condition, if you see the positivity rate, the 5% to 6% test positivity rate, that is, you need almost 15 to 16 times or 20 times of the number of tests that are required for each number of cases to diagnose. Probably, if you consider, forget about 10%, 15%, if you consider India's population coming to like 5% seropositivity by October, if we consider about 5 crore of our cases of Indian population coming positive by October, according to seroprevalence, if you even consider lesser, 2 crore of patients in next 2 months getting positive, total cumulative, we need to test about 15 to 20 times of the number of samples. That is, we need to test close to 30 to 40 crore number of tests within this next 2 months. That is coming to close to maybe 10 to 20 crore per month, compared to what we are doing now is about 2.5 lakh tests per day, which comes to about 30 into 2.5 is 75 lakhs, less than a crore per month. So can we mitigate the disease only by increasing the number of testing? Can we mitigate the disease by further lockdown for next 6 months? These are very difficult ways of mitigating the mortality. So what I try to say in the last parts of my presentation, that initially we were telling that community quarantine is a very important method of containing the disease. Test more, whoever is infected, get them into a community quarantine if they are living in slum-like conditions. If they're living in home, put them in home quarantine. But now, what we understand is probably with the opening of lockdown, with an R0 of 2.7, the caseloads are going to be very, very, very significant. So for mitigating the mortality, the more and more thing that is needed now is early detection of cases, mild to moderate cases, and quickly treating them by identifying and halting their progression into ARDS. Here comes the role of your population scientist. Here comes the role of your demographists. Right now, we don't have the comorbidity and the high-risk burden estimation for each municipal wards. Many of our infected patients will be between 25 years to 50 years of age, who will not have much comorbidity. They are not going to die. Most of our elderly patients and the patients with significant number of comorbidity are at vulnerable points. I would request to the population scientists to give us the total data of comorbidity and high-risk burden for every municipal wards and village panchayats for us to understand how much preparation do we need in the next coming 6 months. We need to plan this data of preparation based on seroprevalence and not RT-PCR positive cases, because I've shown you that RT-PCR positive is only the peak of the tip of the iceberg, and it's varying between 1:10 to 1:300 in different situations where we have less, more or less number of RT-PCR tests per million. We need you to help us in calculating the number of hospital beds, oxygen cylinders, and ventilators that we are going to need if we consider about 2 to 3% of the total number of infected cases who are going to be bad. We need you to give us the age-stratified mortality and morbidity burden estimation from the existing data. Now we have, bulk data of this many people died. Who are these people? We need to understand that what the trend of cases that worsened. Is it due to delay in coming? Is it due to unavailability of oxygen? Is it due to unavailability of beds in the hospital? Is it due to unavailability of ventilators? What are the factors? What is the granularity of the demographic data of cases which have worsened and died? You are the COVID warriors. You are the frontline warriors who can provide us with this data. And overall, I'm very much concerned about the overall mortality that is happening in India. Till now, we don't have overall mortality data of other diseases, overall mortality and morbidity that is happening due to less number of maternity services, vaccination services, and chronic disease services like cancer, heart disease, and blood dyscrasias. This is my appeal to the population scientists for helping us with these things. And my last slide, where I would like to say, is containment, transmissibility, and duration of infectiousness. The 3 points for R0. Containment is gradually going to break if the lockdown is lifted and people will come back out for their jobs and for earning and people are simply bored of getting locked down in their houses. So what happens if containment, if this average rate of contact increases as soon as the lockdown is over? Can we quickly reduce the duration of infectiousness? Not yet, as per the evidence. Favipiravir and remdesivir reduces the duration of infectiousness to a modest extent. but it's favipiravir is too costly. Remdesivir is also very costly, unavailable widely, and it's an IV injection. So the maximum number of transmission that occurs from less symptomatic cases cannot be reduced by reducing the duration of infectiousness. So what can we do to reduce the transmissibility? Nowadays, there are about 2-3 vaccines which have entered into phase 3 trial, and we have understood that through the conventional phase 3 trials, it is going to take a long time and a large number of participants for the vaccines to come in. So nowadays, what I advocate, and it's a personal opinion, I do not represent, I've told you that I am not representing my organization for this view, and this is not the view of a World Health Organization. This is a view of me and a number of people internationally with whom we are working. There is a website called onedaysooner.org, created by a guy called Josh Morrison. There is, you have heard about TED Talks. There is the owner of TED Talks, Chris Anderson. There is, with us, there is the most renowned vaccinologist of the world, Stanley Plotkin, one of the most renowned infectious disease specialists from London School of Hygiene and Tropical Medicine, Peter Smith, and one of the most renowned bioethicists, Nirial. We have been discussing closely over the last 1 month that how can we quickly reduce the transmissibility by fast-tracking vaccines. And the one thing that is coming up, I would ask you to think about it, to discuss about it, to debate about it, is human challenge trials. That is, whatever vaccines are there, candidate vaccines in the phase 3 trials right now. Let's consider the Oxford vaccine, the Sadox one, which is being manufactured by AstraZeneca, the Moderna vaccine, and the Johnson's vaccine. By human challenge trial, we mean we take young people without comorbidities, give them vaccine, wait for a few days, and expose them to the COVID-19 virus, and see whether this vaccine is able to reduce the transmission or not, instead of doing a conventional phase 3 trial where you give vaccine to n number of people in a big community and wait for a long time to see that through routine transmission, how many of them are getting infected. Instead of that, we are talking about aggravating, fast-tracking the phase 3 part through human challenge trial. If you see the infection fatality rate of 20 to 29 years age is closely between 10 to 50 among 1 lakh. And if you see the less than 40 years, it's closely 30 to 70 among 1 lakh. So that is in community, in absence of wonderful facility. If we can provide wonderful fast diagnosis and best available care for all the infected patients who gets infected despite of the vaccine being given in human challenge trials, probably this mortality rate will come down further and we can have almost zero mortality. Okay. So if you see the infection fatality rate that is expected in the human challenge trial, it is much lesser than the probability of mortality of getting pregnant in India, Bangladesh, or South Asia. So the probability that if you see the maternal mortality rate of India, Bangladesh, and South Asia, we are hovering more than 100, close to 200 per 1 lakh population, 1 lakh live birth. If you see the mortality rates of the astronauts of the space programs, we have seen 19 unfortunate deaths of astronauts over the last 50 years among total 550 astronauts who have traveled in the space, which is close to 3.2%. You see, 3.2% is 32 out of 1,000, 320 out of 10,000, and 3,200 out of 1 lakh, compared to the existing mortality rate of 10 out of 1 lakh among young volunteers. And if you see the mortality rate of base jumping, the sport, it's close to 43.7 per 1 lakh. So what I'm trying to say is there is a strong bioethical and a strong scientific drive towards human challenge trial, for championing human challenge trial, for aggravating or for fast tracking the vaccines that may be available. If properly conducted, this human challenge trial can be done by almost zero mortality. And this can actually bring the vaccines closer by more than a few months, which right now we are having thousands of people dying every day. And if we can quicken the vaccine for about 5-6 months, it would be a huge number of people's life which can be saved. Now, I give this idea to you openly, and I know I have jumped over the time, so I'll end my presentation and I will wait for questions. Thank you.
Thank you, Dr. Sayantan. It was really very stimulating talk and we really enjoyed it. You have a very clear message for the demographers and you have touched upon various aspects on the prevalence, on controlling deaths, and how do we really address the COVID-19 situation at this juncture in this country. I think that is quite important. Now, I'm sure there will be many questions, and before getting into the questions, and as Professor Usha has already mentioned, those who would like to ask questions, please type it on the chat box, or we will also give you some time for asking questions. But since there are a large number of participants now, we don't know how far we will be able to identify and how far we will be able to come to you. But it is better that you indicate that you have a question, so that will help us. But I would like to take forward the two major aspects which has been discussed here, and one is primarily on the prevalence. How do you really make policies on what is really happening on the COVID-19? I think that is one of the critical aspects, because you were also challenging demographers really to come out with estimates, etc. So, this is also a very serious issue within the country, because although at the same time we all need data, we all need information, we all need accurate, the most reliable information for the policies and planning, especially in a crisis like COVID-19. We simply know that the data which is available is inaccurate. With data available is very, very limited, even for a projection. I think now even the social scientists are in a concern whether, because there are so many findings comes from their own studies with a limited information. There are so many projections which come, because demographers always think that their projections are much more accurate, because with a robust level we are able to project many of the human behaviors, but not perhaps this pandemic, because many times we always came to know that many of the estimates, many of the mathematical models failed, many of the epidemiological models are under questions, and many of the projections in every day we know that it is not trustworthy. So what do we really do as a researchers? And it is really a challenge for all of us. It was the question which you have raised is very, very important. What is the true prevalence in this country? That is what we need to know, because that really drives our policy one way. Because if we know the prevalence is something around 20% or 30% or 15%, what the ICMR has now 10 to 20% ICMR has telling. If that's the case, I really don't know. Testing may not be an appropriate policy, because we know that it is spread widely. If that's the case, we need to have a different strategy altogether, because enhancing testing may not be the right approach in that case. We need, and also the lockdown, etc., may not be an appropriate strategy. So what we really need to know is what is the true prevalence rate. How do we know about it? Because many other countries of the world have this advantage, because they have the administrative data or the data within the system where really generate and then tell us what is sort of the true prevalence of most of the disease. Although it will not be that far from the reality. Although I'm saying no accurate, there is nothing called a very accurate estimate. At least at least some reliable estimate. But for us, our country, I think it is far from what is the prevalence or the truth. So what do we do with it, and how do we address this in the past? That is what actually even Srilada was addressing. How do you really do it when we had, I think HIV/AIDS is the classic case in that case, because we were all concerned with HIV/AIDS when HIV/AIDS started in India. What is the true prevalence? Finally, at the end of the day, I think neither the administrative data nor the data comes from within the system was not able to help us really to tell us what the real prevalence of India and what is the real approach to be implemented to have to contain the HIV/AIDS issue in the country. So at the end of the day, we need to really get into the real survey, which is through NFHS, and then finally at that time we came to know that what is the true rate of prevalence in this country, which really helped create the policies and programs subsequently and to address this issue. I think it comes to any kind of pandemics or whatever it be. But the question is whether this is the right time to do, whether it is tomorrow is the right time to do, when is it? It is a different question altogether. Whether we have the capacity to do. I'm sure we have the capacity to do, but at the end of the day, we really want to know what is actually the real prevalence. I think also it is also very important, since you have raised the issue of R0, because which is also very vital, because I'm also finding that perhaps this R0, which gives you what is the extent one person will be able to transmit the disease to others. There is also something called a dispersion factor there, which is sometimes people now the papers now say it is a K factor, because the London School of Hygiene and Tropical Medicine study tells that only 10% of the people almost transmit to 90% of the people rest. So actually 90% of them really don't transmit. Even if they transmit, the number of people that transmit is only very less. So what perhaps we would know, rather than the R0, what is actually sort of a dispersion figure in that R0, which would also gives us an understanding who is really transmitting, who is this super spreader, or what we nowadays, the name becomes very popular, this super spreader, because there are incidents of super spreading there and here. So, but who is actually, I don't say it's a super spreader, but at least the people who are really are able to transmit. I think these are the challenges in front of any demographers or any researchers now. We really need to understand who is really spreading, who is not spreading. And if you are spreading, what are your characteristics? And if you are not spreading, what is the behavior you followed actually was not followed? I'm not very sure lockdown is the only reason for not spreading, but there are maybe so many accompanying factors, because anyone who is living alone, even if they are the elderly, may have to go out, buy their essentials, buy their vegetables. I think all are unavoidable, which whatever be the lockdown which we impose. But that way, I'm saying you are likely to spread, but what is that really contain or curtail that you are unable to spread? Mask, people say, is one of the most efficient means, but we really need more and more studies on that. And finally, I think, because the most of the issues which has also been on the mortality, I think that is the very critical aspect which we need to really discuss when we are discussing about pandemics. We know that it is going to spread, it is going to increase the prevalence, the incidence. I'm sure it is going to go up in the country. But the most important critical aspect for this country is that, are we able to curtail the mortality or the death because of this disease? Then how far we will be able to successful. Anyway, as I think both the speakers have already pointed out, the mortality, the case fatality is, fortunately for this disease, is much lower than many of the infectious diseases. That is really an advantage. And both in India, although you may say that there are some underestimates of mortality in the country, but still, even if we account for that, we are very sure that the mortality is not as high as for 10% or something. It can be within the range of 3 to 5% or 3 to 6%, not anything beyond that. That is definite. So what is critically, because we are discussing about the accompanying diseases, which actually enhances your mortality chances, primarily the other diseases, which is especially among the elderly. I think, some of the estimates is also frightening, because I think the estimates which are coming from the Timothy Robertson from the Lancet, it is telling that, not the Timothy, I think there is an Andrew Clark, etc. in the Lancet, which comes at almost 23% of the global population, that is around 1.7 billion, is having accompanying diseases because of which has ultimately threatened your life for the COVID-19. And I'm sure if it is 22% at the global level, in India, it is much higher, although we have very limited information on the comorbidities, etc. in India. But whatever the limited information which we have in many other places, it is really telling, especially among the people who are 45 plus or 50 plus, it is relatively very, very high in the country. So if that's the case, and we have, I'm sure some of this data which is IIPS is publishing from NFHS has limited information, but we are also about to launch the longitudinal aging survey in India, which is LASI study, which the data will be out very soon. So, which will give you much wider information on what is really the accompanying morbidity among the population of India, which may have throw much more light on at least at the state level, or perhaps sometimes wherever necessary at the below state level. So that could be another evidence. But I think that is where the country is lacking information. I think is challenge to demographers and the public health specialists to address this issue, because that is where interventions are really needed at this point in time, and how do we control it. I think the public health preparedness, I think Srilata has spoke about what is the important for this country. I'm sure there may be many questions on that aspects, how that is the second way we should address the mortality challenges on that. I think I should not take much time now, so I will leave it to a large number of participants, because there are around 225 participants in this talk. So naturally, I'm sure there will be many more questions. So I would invite all others to come out with questions, either type it in the chat box or maybe indicate to us. We will be able to take the questions to both the speakers. Thank you once again. It has been really a population day treat, I can say, because it was fascinating, both the talks. And I thank you for very much on these exciting talks. So perhaps, Professor Usha, you can really coordinate and maybe take up the first few questions and then take the rest of the questions. Okay, over to Usha.
Thank you, Sayan, for very lucid presentation, and Professor James for comprehending the discussion that came emerged from both the presentations. So I'm just looking at the chat, and there are two questions which you already have been typed, and I'll take them in the order that they have been typed in. The first question is by Dr. Sajita from PRC Kerala, where she is asking, is it true that in India, Bharat Biotech has invented vaccine for COVID-19 and it will be applied among humans on July 13th? So if anybody would respond to that out of the two speakers.
Okay. So yes, Bharat Biotech has produced a vaccine. So, but it has not entered into, or we don't have the phase 3 trial results for that. Bharat Biotech's vaccine has, being a product of India, it has been in a strong interest of ICMR, and ICMR has actually instructed a lot of hospitals and medical colleges to start trials on that. But 13th of July, nowhere. We are nowhere close to 13th of July as far as Bharat Biotech vaccine is concerned. And if you see the international timeline of vaccines, Bharat Biotech is still now not in the leading 3, 4, or 5 candidates of vaccines recognized globally. So 13th today is 11th of July, so no question of getting a vaccine by 13th of July. Absolutely.
Shri, would you like to add anything?
No, I think Sayantan knows much more about vaccines than I do, so I'll leave it.
Thank you. So the next question is by Mr. Akhil PM, and his question is, COVID-19 is affecting for the second time to the recovered person. Please comment. Is it really so?
Again, I should leave that to Sayantan, yes.
Yeah,
sure.
So yes, there has been cases. Now, whether it is reinfection or reactivation, there are doubts among this. A most robust study has come from following up of 91 patients in South Korea, where it has been seen that about 6% of the patients do not have a lingering antibody response against COVID-19. So these 6% patients are definitely vulnerable to either reinfection. Somebody is now, some researchers are also proposing of a factor of reactivation. You know, certain viruses get dormant in your body and gets reactivated later on. We have seen the cases of hepatitis B. We have seen the cases of particularly varicella zoster virus. You have chickenpox in your early childhood, and the entire life you are fine. And at the age of 70, you get zoster, shingles. where the virus was lying dormant in your neural cells in your vertebral cord, and your immunity comes down and it comes out as shingles. So these kind of, we don't have enough time to say that whether this COVID-19 virus will reactivate or not, but there has been specifically diagnosed cases of low antibody and no antibody, which shows that there is probably a possibility of reactivation among close to 6% of infected patients. Yes.
Okay. So just a suggestion to our Mr. Avinash, one of the attendee, Mr. Akshay Mishra, want to ask the question. So while you unmute him, I'll take up the next question in the interest of time. So the next question is by Mr. Ravi. And the question is, who is more desperate to bring forward vaccine by compromising all the standards, ethical protocol? Is it the scientists who are more interested or more pushing to it, or the pharma companies?
I may volunteer to answer.
Or anybody?
No, you should answer, because you brought up, I think it was part of your presentation. So
okay, wonderful. So if you see the race of vaccines, so your question has a lot of layers. Your question is very important in this particular aspect, as I have recently, we have been pushing for fast tracking of the vaccines. If you see the history of vaccines discovered by Edward Jenner from the milkmaids' pustules of cowpox injected amongst people who are vulnerable to smallpox, which led to the first vaccine of the world. If you see the history of rabies vaccination by Louis Pasteur, where he cultured rabies virus, rabies is most deadly disease with 100% mortality. There is almost very few, no other infectious disease as close to rabies as 100% mortality. With dog bite, if we didn't have the vaccines and the serum for rabies, it would have been 100% mortality. So if you see the history of vaccines, it has been traditionally scientists who have been engaged in vaccine manufacturing, vaccine research, and have come out through their altruistic and quest of science. Vaccine, there has been a significant anti-vaccine movement all over the world who have shown that vaccines have a lot of side effects. There are reports of vaccine-derived poliovirus. There are VDPV infections. There are reports of, certain strains of poliovirus 2 or certain other strains which mutate while oral polio virus vaccine is given and gives rise to polio-like conditions. There has been a history of neurological disabilities occurring due to certain vaccines. There has been history of excessive mortality occurring due to a older strain of measles vaccine that has happened in the world. If you see the recent example of dengue vaccine, the Sanofi vaccine of dengue that was trialed in Brazil and Thailand, there has been cases where there was vaccine-induced excessive disease. So there have been problems of vaccines as well. There are also people who have been telling that, yes, vaccine manufacturers actually earn a lot from promoting vaccines. Now, if you see the present condition of COVID-19 vaccine pipeline, if you see the vaccine that has been produced, which is now the #1 candidate, is the Oxford University vaccine, the Shadox 1 vaccine, which has been prepared in the lab of Professor Ian Hill and Sarah Gilbert, the Edward Jenner laboratory, which is an university laboratory. The two companies which have come forward for preparing these two vaccines in large scale, AstraZeneca and the Indian company Serum Institute, has clearly said the message that they will show the cost that they are incurring through their the production of vaccines, and they are not going to profit from the production of these COVID vaccines. If you see the other vaccine candidates, the Moderna and the Inovio vaccine candidates, there is no such declaration from the companies that they are doing it for altruistic purpose, that they are giving it, they will be giving it without profit. There is no such declaration. So it's a question which is tough for me to answer right now. But if you ask me about fast tracking the vaccines, the consortium that is trying to be formed right now, about which I'm talking. Sir Stanley Plotkins is a university professor who has written the textbook named Vaccines, which we have all grown up reading. Okay, he's an octogenarian, 80 plus years age, and he has got no association with the vaccine manufacturers, number one. Number two, Josh Morrison, who is driving the project, onedaysooner.org, is a person, is an advocate by profession, who is believer of free knowledge, open knowledge, and who has donated his own kidney to a complete stranger for the cause of altruistic donation, altruistic volunteering. So I don't doubt Josh Morrison's effort for benefiting certain pharma companies. I am not associated with any pharma company, and I am a United Nations civil servant by profession, and it's barred for me to enter into any kind of direct relationship with any of the pharma companies. And regarding TED Talks owner Chris Anderson, who has been pushing for this, the entire concept of TED Talk is free dissemination of knowledge and openness. What we are planning is, through this fast tracking of vaccines, we are giving an open call to the pharmaceutical companies to give their vaccines, to the universities to give their vaccines, and we can have multiple arms tried, because we need very small number of volunteers for the human challenge trials. So there can be 4 or 5 different vaccines, entirely transparent database, an entirely open system for the world to have vigilante over it. So I don't think that with the human challenge trial and the fast tracking of vaccines, it is led by the pharmaceuticals. I believe that I still believe in the altruistic principle of greater good and scientific interest among scientists and volunteers. So I would take the vaccine effort more by, in a positive way. Dr. Usha, you are muted.
You are muted, Usha.
Okay, sorry. Now is it okay? Yeah. So
Yeah.
I'll take 2 questions that are addressed to Madhvi, which is Yashri now. Okay. Yeah. So the first question is, how can we cope mental health challenges during COVID-19 situation? That's one. Second question is about what components should be added to Ayushman Bharat and health and wellness centers for addressing the data gaps in health emergencies? If you could take these 2 together. Thank you.
Yeah. So I'll come to the mental health issue second. But in terms of strengthening Ayushman Bharat and the health and wellness centers, I think the important thing is for the health and wellness centers particularly to function in the way that they were meant to do, which is to have all the services and the people in place who can do the kind of community outreach and the kind of community-based work that they were meant to do, right? So if the local health and wellness center or the primary health center, as used to be, truly functions as the first level of the health system and provides the kind of comprehensive primary care that they're supposed to provide, that means that they have that connect with the community, whereby through outreach workers and through the institutional base that they have there, they are able to track and support through their own community networks and provide all the basic kind of information, collect the data, provide the services, and be the first line of service access to people from various communities, whether it is urban or rural. What is happening now, unfortunately, is that that function is extremely underserved. So there are often not adequate numbers of personnel, because if you see the kinds of vacancies, vacant positions of ASHA, of ANM, of PHC medical officers, and so on and so forth, it is alarming. There are very few states in the country that can say that they have an adequate number of people out there at the community level providing the kind of services that are actually part of their job description. If that level could be properly funded and capacitated, and the personnel, well-trained personnel with the adequate resources and tools and material that they need, if they could be serving in those places, they actually could do this job and they could do it well. So, in fact, under the COVID, in the course of this pandemic, there have been a few directives that have come down from the Ministry of Health and Family Welfare, which have asked for a small task force to be created at the community level in each Gram Panchayat. So when you have the Village Health, Sanitation and Nutrition Committee already in place, now they have been tasked with collecting data and providing quarantine facilities, etc., across the country. Now, has this worked? In some places it has worked. Right now I'm doing a study in Udupi district in Karnataka, where we are looking at what has been the response of communities working along with the health and wellness centers or primary health centers to do that kind of community work and to be able to provide that kind of community-based surveillance and data collection. And in some places, they have done actually a reasonably good job. Now, what are the factors that, facilitated that is something that we want to study in greater depth and which we are going to do in the next few months. The issue of mental health is much more complicated, because there are groups that have been advocating for community-based mental health services, which is globally considered to be really the gold standard for which we should be aspiring. But we have much more of an institution-based mental health system. And until, the community level structures are put in place to really genuinely provide the kind of mental health support that people need, especially in a crisis like this, we will have huge gaps. The gaps are somewhat being filled by NGOs and other organizations that are setting up helplines and community outreach and so on. But those are patchy. It's not available, across all geographies. So unfortunately, at the moment, I think we are very ill-equipped to provide mental health services in these kinds of situations, or even otherwise, even under normal circumstances.
Yeah, Shri wouldn't leave you two more questions waiting for you. So, and I'm just not reading out by the names of the persons who have given the questions, because there are questions which are repetitive. So I'm just trying to put them together, right? Just in the interest of time again. So the two questions that relates to you, one each about how to address community feedback and stigma attached with COVID-19. That's first question. And second related question is as to how to restore the routine services in the health system, like the immunization and the productive health services that we talked about post-COVID pandemic. So if you can again take these two together.
Okay, so this question on stigma is very critical. It's a very important question, because I think that is one of the reasons why people are not coming forward to even get tested, even when they are afraid that they might have the symptoms. The fear is there. There are two fears, actually. One of the fears is that they will be packed off to a quarantine center and they will be isolated from their families and everybody else, and all their contacts will be traced, and all of the whole machinery will come into place. And they don't want to deal with that because they don't know how the government is going to treat them. That is one aspect. But the other aspect is definitely about the stigma. And I myself, know people who have held back from coming forward and, getting tested or whatever, because they're afraid of how they're going to be judged. And when you even see, the way that the, last rites of people who have died of COVID, how that has been handled. And I don't mean only in India. This is true even globally. I was shocked to find that there's a mass grave that they have created in Long Island for all the cases, mortality to deal with the people who died in New York and so on. So this is a global problem. And I think the messaging, and this is where the risk communication message needs to be more nuanced. I think the message that has gone out and that has been done, I think, so that people take these actions seriously, right? So when all the messages were going out about washing hands, keeping distance, wearing mask, etc., in order to increase the likelihood of compliance and to make it much more taken seriously, I think this idea that somehow, getting infected almost immediately spells, the beginning of the end, that means automatically that you're going to, you will not survive. That kind of message, that kind of dread that has been generated from some of the messaging, I think that needs to be thought about very carefully. And this was even the case in HIV, because I remember initial messages that came out on HIV had a skeleton. You get infected with HIV and then the next image is that of a skeleton, and lots of people objected very strongly to that. And because it further stigmatized an already scary and dangerous condition. So I think that is something that really needs to be addressed. I got messages from my students saying that now suddenly we have realized that most people survive. It's a very small percentage of people who die. And all this while we were living in so much dread because it seemed as if, it's you get it and it's like a death sentence. So that is something that needs, I think, a lot of work about the stigma. So Usha, in this process, I forgot the other question. Did I address both of the questions?
Yeah, you did cover, Shri. You did cover, yeah. Thank you so much. So I have now 3 more questions that I have combined from various questions that have been typed in for Dr. Sayan. The first one is about how to project COVID-19 future scenario when it does not follow any distribution or any growth rate pattern. That's one question. Second question is whether the death rates due to COVID could be projected using some indirect methods. And finally, there is a question related to that when we have so much of comorbidity prevalent in this country, how sure can we be in assigning the cause of death that it is due to COVID actually? These are the 3, I have put many questions together into these 3 just to summarize so that we save time. Can we please unmute Sayan?
I'm sorry, am I back? Yeah, so thank you for the questions, and I also have extracted a few questions from Professor James' summarization. Professor James also wanted to, ask that what is it that is needed? We have the figures, we have what exactly is needed to be done. Okay, so along with this projection of cases and projection of death, I will come to the last question later on, comorbidity. I will also try to address the what is needed to be done kind of thing. So what I believe, number one, is the number of cases that we are seeing are actually much lesser than the number of cases that is actually happening. And as Professor Srilekha has said, that one of our students have said that it's actually much less number of people dying. Yes, the initial mortality rate that we saw of 3 to 6%, which came down to 6% initially, then came down to 3%, etc., is a mortality rate where we had the denominator of RT-PCR positive cases. And if you see my slide where I have shown that in Geneva, we have RT-PCR positive is to community cases about 1:12. In Delhi, we have RT-PCR positive is to community cases about 1:30. In Santa Clara County in USA, we have RT-PCR positive to community cases of 1:55. And in Calcutta, we have 1:300. That means we are actually seeing only a few minuscule number of cases than actually happening. Coming to the question of super spreader that Professor James has asked, I would like to use the term spreader than super spreader. If you see the recent WHO statement, that actually if a person remains completely asymptomatic in its phase of the COVID-19 infection, then this asymptomatic person is less liable to transmit because they don't cough and sneeze. The most liable to transmit patients are the pre-symptomatic and the mildly symptomatic cases. Because if you're severely symptomatic and if you are panting and if you're out of breath and if you are coughing and you definitely have COVID kind of thing, you are in more chances of getting yourself limited to your house or getting yourself into a hospital, into an isolation facility, and people getting afraid of you. The number of people who transmits more are the pre-symptomatic and mildly symptomatic patients who are sneezing and coughing, shedding the virus, but is otherwise well. And due to the lockdown and existing economic slowdown, you just consider a Uber or a Ola cab taxi driver who is 35 years of age and is having 1 or 2 sneezes and a little bit of running nose. Will he get himself isolated for the next 15 days, then losing maybe 500 or 1,000 rupees per day kind of income for the next 15 days, where he can manage the entire symptom with a few paracetamols and a handkerchief? So these are the patients who are super spreaders or spreaders. Okay. And these are the patients who are most often undiagnosed by the RT-PCR positive, because till today, if you see the criteria of the government hospitals of getting tested in a government hospital, if you have a mild cough and cold kind of thing, and if you are afraid of getting yourself isolated, you don't actually have a system where government reaches out to you and gets your sample and get you tested. So the kind of denominator that we have to have for planning our resources, for planning how many beds we need, for planning how much oxygen we need, for planning what is the extent of the problem and what are the mitigation measures needed, we have to have the seroprevalence data. And the seroprevalence data can be very well collected by standard your randomization methods and by doing ELISA. This is a part of the question. And regarding projection of cases and projection of deaths, I would say deaths are largely noticed. Deaths are more recorded than cases. The number of COVID-19 positive cases burden that we have compared with the RT-PCR positive cases and the number of COVID-19 related deaths you have, I will say that COVID-19 related death number is more closer to being accurate. So the projection would be, see, if Dr. James told about the new factor which is replacing R0, the kappa factor, that's very good, because if you see R0 2.7 means that at the end of the epidemic, totally about 80% of the population will get infected. R0 3 means at the end of the epidemic, about 90% of the population will get infected. But this is not happening, right? This is not happening because a large part of the population is not transmitting the disease, is completely asymptomatic, or is getting themselves isolated in their house or hospitals and is actually not giving out the disease as the R0 should predict it to be. That's where there comes the different factor. So if you want to project the cases, what we have to do is, if you have a seroprevalence data, and if you ask all the seropositive patients that in last 2 to 3 months, did you have any such disease, then you will have a true prevalence of symptomatic cases versus asymptomatic cases. Seroprevalence will give you the overall antibody level. All the positive cases, you go back and ask that in last 2 months, did you have fever, cough, cold and all? Suppose 40% of them have a mild history of cough, cold, 10 of them were having severe fever and cough and cold and went to hospital, and rest 50% had nothing. So you can predict, if your data is well randomized in a given population, that you have about 50% asymptomatic cases in this. And definitely when you are doing seroprevalence, you don't have a mortality. Okay. Now, if you have a total death rate in a given population, and if you project that on a denominator of seroprevalence, you get a more or less good, fair idea of COVID-19 mortality rate per infection. That is the infection fatality rate. And you have to stratify that according to age. So we can definitely project number of cases and number of deaths if we can have granular data of the mortality. Right now, if you go to the Ministry of Health and Family Welfare website or the WHO website, you will not have a granular data. You will have total number of cases, total number of deaths. You know, we also don't have the value whether this total number of positive cases or total number of tests done are on unique population, or there are repeat testing, because I have treated many patients who have been tested twice or thrice to find out if they are free to be if they are free to be going back to their family. Okay, previously we had an idea that RT-PCR positivity means infection. Now we have got an idea that people may be RT-PCR positive because of dead virus for long, and we actually leave the patients after they are completing about 10 days from the beginning of symptoms or 3 days from the end of symptoms, even if they are RT-PCR positive. So we had a lot of number of cases where RT-PCR was actually done on a single patient twice or thrice. So the number of tests that we have, the number of positives we have, we don't have the granularity. If we don't have the granularity, we can't say that we will project the number of cases or deaths or whatever is required in a proper way. So that is my appeal to the population scientists. And the last question is comorbidity. See, if there is a disease where fit people are not dying, young people are not dying, and people who have severe comorbidity, people having hypertension, people having a pre-existing lung disease, heart disease, and hypertension are dying. You know, there are people with cancers dying, elderly people dying. These people were not dying when the COVID-19 was not there. Na? They are dying because COVID-19 has caused acute respiratory distress syndrome in presence of the comorbidities. How can we tell that this is not due to COVID-19? This is due to COVID-19 in presence of comorbidities. Initially, there was this kind of arguments from certain states coming. Certain states were telling that this is the COVID-19 related deaths. These are the comorbidity deaths, who are also COVID-19. But if a person dies with hypertension and heart disease while he is having COVID-19 and he was not dying while he was not having COVID-19, my father have a CKD, chronic kidney disease, and is under hemodialysis thrice weekly. If he gets COVID-19, he has a very high chance of mortality. I know that. Now, if he or any such person has such an untoward incident with COVID-19 infection, we can't attribute that to the comorbidity. We have to attribute that to the COVID-19 in presence of the comorbidity. Thank you.
Hello. Thank you.
Yeah.
I think we are also running short of time now. We may have to limit the questions. So let's see how many more we can take. We will stop within another 5 minutes.
Sure.
Yeah.
So I just want to announce here that Dr. Srilata has to go for some personal engagement that she has already committed to. So if she could be excused, and we will take up the questions that have been addressed to her and forward it to her later on, and we can get the responses and put it on our IIPS website with the report that we will display of this event. Would that be okay?
Usha, I will be more than happy. Thank you so much. I will be more than happy to answer. And if people want to send even to my email, you can share my email, and they can. I have no issues with that. But thank you so much. And I'm sorry I have to step out, but you know, unavoidable circumstances. Thank you for giving me this opportunity. James, Usha, thank you very much. We'll be in touch later.
No, thank you very much for being here. Thank you.
Yeah, I want to thank Sayantan also for a very interesting talk. Thank you very much.
Yeah.
Okay.
Thank you.
Bye. Okay. Bye. Bye. So again, I have next lot of questions, Sayan, for you that I summarized. And again, I mean, I have listed 4 key areas where the questions have been mentioned. The first one relates to that we have this fatality rate, which is very low in this country. But is that enough? Because if you look at of the deaths in their absolute numbers, they're significant. So should we ignore that component completely and only say that we have a low fatality rate and so we are performing good? This is first question. Second is about that if we can identify a single solution which we consider that which will be most effective to address the COVID-19 spread in this community or in this country, what would that be that of your choice? Then the third question relates to whether this reproduction rate at the R0, basic reproduction rate, it only gives you the rate of basic spread, but it does not give you the pace of the spread. So should it be used for policy purposes? That is third question. And finally, whether there is an association between individuals' immunization history and acquiring of COVID-19 infection. Four questions. And I think other questions we will keep in record, and as I said, we will share with the relevant speaker and then get back to the participants here. Please unmute Sayantan. Avinash?
I'm sorry. Yeah, so first of all, the fatality rate is low, but the total number is high. So should we consider the total number or the fatality rate? See, I believe the fatality rate is actually much lower than still we are having, because we are having a wrong denominator that I have been repeatedly stressing on. If in Calcutta we have a 300 number of community cases per RT-PCR positive cases, if in Delhi we have 30 or 50 number of positive cases, actual burden per RT-PCR positive cases, we are having much lower infection fatality rate. If you see the rate, but the total number of people who are dying matters to us. If my father dies in my family of 6 members or 5 members, I can say that, okay, only 20% member of my family has died, nothing, problem. You know, that's not the case. We can't afford to lose a single life which can be saved. So despite of the low case fatality rate, we can't say that we can ignore the problem because of its high transmissibility. If you see, I completely agree to Professor James when he raised about the new factors that are coming up and replacing R naught because of the variability in transmission. But if you see the total number of cases that are projected to get infected, forget about the R naught of 2.5, which projects a total number of 80% of total population of India will get infected. See, being a population scientist, you can easily download a table which shows that if R naught is 1.5, how much will be the total number of cases, that is the area under curve of the epidemic. If the R naught is 2, how much? R naught is 2.5, how much? 3, how much? 10, how much? Okay, there are standard tables. Roughly it is 2.5 is almost 79%. If it is 3, it is almost 89, close to 90%. If R naught is 2.5, totally 80% of the population of India can get infected. That is the total volume. If that is even not true, okay, if I consider, forget about 80%. Even if 5% of the total population gets infected, that is 5 crore. And if 1% of this 5 crore dies, we take the minimal thing. We are not taking 3%, 4% mortality, 1%. Then also it comes to 5 lakh deaths. So absolute numbers simply cannot be ignored because of low case fatality. There is no case of complacency at all. Number 2. Single solution. What is the single solution that I can give? I will come to the question at last. Number 3, R naught value is required for policy or not? See, I'm not a fan of the R naught value because, you know, it has got a lot of layers, a lot of problems. You know, it's a retrograde calculated value and it can't take in action people's actual movement. You know, the R naught that we have right now is from the lockdown period. If the lockdown is lifted, if the Mumbai suburban trains start to have crowds as they usually have, how many of them will be able to carry their mask in that crowd? I doubt. If the Calcutta suburban trains and the metro and the buses have the amount of people transported, the regular amount of people that are transported through the transports, I believe that all these calculations are going to go haywire. So, but we need data, we need points, we need reference points for projecting the preparedness, whether it is R naught, whether it is seroprevalence based, whether it is whatever data we have, and if needed, we need to produce a new index. That is your role, to find out the seroprevalence, to find out the granularity of the seroprevalence, to find out the age classified mortality, morbidity data, and if not R naught, then a new index. But we need to have values, we need to have figures for projection. Number 3 is a single solution, right? The last question. Yeah, so the single solution that I have. So, so definitely this is the concluding remarks of the seminar. Okay, see, I'm 37 years old. Okay, and I have entered the medical school in 2002, and I have a complete post MBBS internship residency. I have an infectious disease and microbiology experience of only 10 years, 2010 to 20. So definitely what solution I am going to tell you is not the actual or accurate solution. It's just a personal opinion from a very junior scientist who is trying to understand the situation. See, what I understand right now is we need to test more, but we can't achieve the optimal testing numbers. We can't achieve with the number of projections that we are having. So we have to triage the testing. We have to understand, we have to triage the testing for those who need most. Who needs most? Everybody will say we need most. See, right now, our main aim is to reduce mortality, is to reduce fatality, and quickly open up the status quo, the stalemate situation that we are having. If we open up the status quo, if we open up the stalemate situation, cases will start increasing geometrically. What to do then? What is needed is, we need to have decentralized and easy testing method so that people can test at their homes, like the pregnancy testing kits that are available right now. Nowadays, we are moving towards that kind of testing through the rapid antigen testing, which has a very high specificity, close to 100%, but the sensitivity is low. That means if you test negative, the sensitivity is close to 70 to 80%. If you are negative, you can't be sure that you are negative. For 20 to 30 cases out of 100, you can be wrong. But if you are positive, you can be sure that you are positive. So decentralized testing, number 1. Number 2 is people like you, population scientists like you, coming up with the actual number of cases with comorbidities and high risk for the doctors and the policymakers to understand how many number of people will actually go bad and require oxygen and ventilation in the next few months, and prepare according to that. Number 3, what we are seeing is many of the patients are getting absolutely fine with simple oxygen therapy. Oxygen has become the new antiviral. Happy hypoxia is a term that is being used by the doctors. That is, patients are becoming hypoxic, low saturation, but are not having too much of breathlessness. So if you can identify influenza-like illness very early, that is cough, cold, and fever, if you can identify how many people have high comorbidities and high risk in this particular municipal ward or in the village panchayat, and if you can early diagnose saturation among the influenza-like illness people, even if you don't have RT-PCR for all, and if somebody is having less than 94% saturation, quickly shift them to a local facility with only oxygen and follow them up, you can probably mitigate a large number of mortality instead of only ramping up the number of ventilators and ICUs. And the last point that I would again like to say, the only one thing that can purely take out us from the crisis of this pandemic is vaccines. So fast tracking of vaccines by any means has to be the mainstay. Somebody is writing about herd immunity. See, for herd immunity to be effective, we need 65 to 70% of herd immunity. That means 65 to 70% of the population getting infected. That is the worst nightmare that we are wanting to have. Like 65, 70 crore Indians getting infected and 1% of them falling ill is like 65 lakhs of death for getting herd immunity. So definitely immunity is needed, but not herd immunity, but acquired immunity through vaccination. So these are my final comments.
Okay, I think that was excellent. Yeah, thank you so much. It has been very exciting debates as well as the question answer session. We really enjoyed it. I think since we are running very much short of time now, so we will go to the final part. Over to you, Professor Usha, to have the.
Thank you very much, Professor James. I request Professor Archana to propose vote of thanks, please.
Yeah. A very warm greeting to everyone. It's my privilege to propose a vote of thanks on the occasion of World Population Day 2020. Today, the corona has affected everybody directly or indirectly, and it has created several crises in a several form, and we all are suffering. So on this situation, IIPS has organized a symposium for World Population Day 2020 on a demography and pandemics, lessons learned and way forward of COVID-19 pandemics for India. And we had two wonderful speakers today, Professor Srilata Rao and Dr. Sayantan Banerjee. And both presenters have brought many important issues of concern. Professor Rao, she presented that how health policies have worked in past and present, what are the lacunas and gaps, and how we should work in future so that this pandemic can be controlled. So what should be the preparedness? And she highlighted that in this context, multidisciplinary and multi-sectoral approach is very important to deal with such public health issues. The second speaker, Dr. Sayantan, who is by profession a medical doctor, he put the perspective of clinicians on the role of demographers in pandemic. And he suggested various areas of for the demographers where these demographers can play a effective role in controlling the spread and containing the spread, and then analyzing and then creating a good public health environment. So friends, we must mention our deep sense of appreciation to both speakers for their insightful and valuable deliberations. We hope their ideas and suggestions will help all the demographers to come up with their new strategies. I, on behalf of our publication cell, our team, I express my gratitude to all eminent invitees from the state offices, the academicians from different institutions, PRC, NGOs for their active participations. In this series, I would also like to thank our former faculties of IIPS, our esteemed colleagues, IIPS alumni, staff, students, and all who participated here and spent their time for success of the program. Without your presence and involvement, friends, this program would not have been successful. So thank you so much. Well, in this series, I'd also like to thank Professor James, our director, who has been providing a constant support and guidance and also autonomy in organizing this event. So thank you so much, sir. And webinars have become a way of communication in this crisis time. And in this, very basic infrastructure and technical support is always required for uninterrupted connectivity. So in this context, I extend my heartfelt thanks to our technical team led by our system manager, Mr. Anjani Kumar Mishra, and Mr. Avinash for handling the meeting very efficiently. Friends, we have been fortunate enough to be backed by a team of very motivated and dedicated and sincere colleagues, Mr. Babu Santosh Kumar and Dr. Murugeshan. We are very thankful for their enormous cooperation in organizing this event. My sincere thanks to Professor Usha Ram for planning and leading the team. She has been constantly supervised all the activities and how the program has to be successful. So she has been very active. So thank you so much. So at the end, I thank one and all being with us this morning. Have a nice day and have a safe stay. Thank you, everyone.
Thank you. Thank you all.
Very much.
Yeah.
Thanks one and all. And it was really wonderful having it. There are questions pending. I'm sure we will be able to address and revert to you guys. Thank you so much. Yeah,
Thank you.
Professor
Yeah.
James.
Yeah, we close this session. Okay, thank you for all your participation.
Thank you very much. Thanks, everyone. Bye.
Yes.